The talk is entitled, as you can see, Pain Management, Past, Present, and Future. So this is a basic introduction to pain management for all of you guys. Standard disclaimer. Nobody paid me to do this. In fact, I'm paying to do this. So I have no commercial interest in this, no grants. I borrowed some slides and images and videos from St. Jude Medical, spinal modulation, and Boston Scientific, and Hydrocision. I'm not going to go through all this. We went through this. That's the old medical school. All of you can recognize the principal's office, right? That was Dr. Shamla Bhaskaran's office there. And this is the new medical college. So I was in that medical school, not in this one. So, but most of you recognize the old medical school. Once again, Endaro Mahanubhavulu Andariki Vandanamulu. That's my favorite kriti. What are we going to do in this talk? We're going to talk about pain. We're going to talk about pain management, the history of pain management today, pain syndromes that we see as pain management physicians. What is interventional pain management? Interventional techniques that we use, equipment that we use, pain management in India, what we are doing in India, what is being done in pain management in India now, and the future for pain management. Guys, ready then? Let's go. Pain. So what is pain? This is the definition, International Association for Study of Pain's definition. Every single word in this is important, so please listen up. It's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Every single word is important. So it's an unpleasant it's an unpleasant sensation, we know that. It's both a sensory and also an emotional experience. It may be associated with actual tissue damage or may not be. So a good example is a herniated disc, right? That is tissue damage, right? So that can cause pain, but a bulging disc can also cause pain. That is not tissue damage, that is potential tissue damage. So, or described in terms of such damage. John Dryden is a famous British dramatist and a philosopher. He put it very nicely when he said, for all the happiness mankind can gain is not in pleasure, but in rest from pain. And pain has been incorporated as the 5th vital sign in the United States. So the point I'm trying to make is pain is very important. So when you go to any facility in the United States, they take your temperature, pulse, respirations, blood pressure, and pain. So that is the 5th vital sign in the United States. Having talked about pain, let's talk about the pain management. We always talk about history, right? Why do we always talk about history for any subject? Those who don't learn from history are doomed to repeat it, right? So that's the point. So we always have to learn from what our predecessors did. The management of pain, like the management of disease, is as old as mankind. So man has had pain right from the very beginning. To appreciate the significance, it's important to reflect on the origins of the words pain and patient. Tell me where the word pain comes from, guys. Come on. Pain. What is the root for pain? Not you, Dr. Joshi. I don't expect you. The postgraduates. Pain. Where does the word pain come from? Come on, guys. Come on. No? Pena, which means punishment, right? So sub pena, you hear the legal term sub pena, right? So pena is the word punishment. And what is patient? Comes from the Latin word patior, meaning to endure suffering or pain. So the word patient itself has pain in it. So that's where we come from. Going back to the very early history, Indians believed that pain was experienced in the heart. Chinese identified multiple points in the body where pain might originate. And draining the pain points by inserting needles may have been the origin of acupuncture, which is over 2,000 years old. We come to the Greeks and Romans always in any kind of history. The ancient Greeks were the first to consider pain to be a sensory function. See, this is where we come to pain as a sensory function that might be derived from peripheral stimulation. Plato hypothesized that the brain was the destination of all the peripheral stimulation. Aristotle advanced the notion that the heart was the processing center for pain. Guess who won? The guru, right? Plato was the guru of Aristotle, right? So Plato was right. So we know now that the brain is the processing center. At least today, we think that brain is the processing center. So that's where we are in our knowledge of pain. 400 years later, Galen re-emphasized the model of the central nervous system. Who's this guy? Anyone? 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 No? This guy is René Descartes. He made a very profound statement. He's known for this statement, cogito ergo sum. I think, therefore I am. So he's a French philosopher, scientist, and a mathematician. And he's the one credited to give us the first theory of pain. Descartes' description of pain conduction from peripheral damage through nerves to the brain led the first theory that's called the specificity theory. That's his picture, that he drew this picture. And you can see this picture here. This is a little guy here with his foot in the fire, and the fire is causing the pain. There's a pathway from the foot all the way to the spinal cord to the brain. So that's what Descartes said. Specificity theory is based on the tenet that injury activates specific pain receptors that in turn project pain impulses through a spinal pain pathway to a pain center in the brain. So that's where we come from, this specificity. So there is an injury, it is carried by a pathway to the brain. That was the first theory in pain, conduction of pain. There are a lot of people who revise these theories. Schiff revised that on animal research and proposed the theory that each sensory modality, not only pain, was transmitted along an independent pathway. So touch was a different pathway. Pain was a different pathway. And then these guys, Goldscheder, Newton-Bosch, and Livingston, proposed several pattern and dorsal horn summation theories from 1900 to 1950. Who are these two guys? Anyone? Anybody? Ron Melzack and Pat Wall. Ron Melzack on the left and Pat Wall on the right. These are the Amitabh Bachchan and Dharmendra of pain, like Sholay. Right? Sholay was a watershed moment in Indian film history. So, you know, movies before Sholay and movies after Sholay. So pain management before these guys and pain management after these guys. So, because these are the guys who gave us the, what did they give us? Gate control theory, right? The gate control theory, these two were responsible. So, in 1965, Melzack and Wall proposed the gate control theory, which is based on the following tenets. Transmission of nerve impulses from afferent fibers to spinal cord transmission cells is modulated by a spinal gating mechanism in the dorsal horn. And the spinal gating mechanism is influenced by the relative amount of activity in the large diameter and small diameter fibers. Activity in the large fibers tends to close the gate, and small fiber activity opens the gates. That's why it's called gate control theory. The spinal gating mechanism is influenced by downward activity from the brain. So that was the first time that somebody mentioned brain as an influence, not only in perceiving but also modulating the input. That's the first time brain was brought into the picture as a modulating influence. So what happened with the gate control theory? Psychological factors which were previously dismissed as reactions to pain were now seen to be an integral part of pain processing, and new avenues for pain control were opened. Prior to that, they were cutting nerves, right? They were doing cordotomies. They were doing cordotomies, and they were replaced by a host of methods to modulate the input, which include TENS. We know what TENS does, and the spinal cord stimulation in acupuncture. So once this theory was published in 1965, there was a lot of argument about this theory. Lots of arguments, lots for this theory, lots against the theory. And then after that, in the 70s is when this was accepted, and they started publishing it in textbooks in the 1970s. Now, Melzack didn't stop there. Melzack went on and did further studies. And what he did was he developed the role of the brain in pain by proposing that specialized systems in the brain are involved in the sensory discriminative, motivational affective, and cognitive evaluative dimensions of pain. And he collaborated with Lozer and described several pains in phantom bodies of paraplegics with verified total sections of the spinal cord and proposed a pattern generating mechanism above the level of the section. So phantom pains were a big conundrum for all of these guys. Okay, so you have the gate control theory, very nice. If you have a pathway in the spinal cord, that's great. But where is phantom pain coming from? You don't have a limb. right? You don't have a limb, but you have pain. So how do you explain that? The gate control theories till that point could not explain phantom pain. And these are phantoms. You can see the dark shaded ones are the phantoms. And with time, some phantoms grow into the limbs. If you can see that, the stump of the knee, you can see the foot grown into the stump. That's a phantom growing into the stump. Interesting cases, two of these guys. The top one, he was riding a motorcycle. He crashed, and he was paraplegic at about T7. But when he woke up, he said that he was still, he felt like he was riding the motorcycle. So he felt his legs were up like that. He had a section at T7. He had no business feeling that his legs were up, but he said that his legs were still up. So that you can't explain. This is a phantom body experience, right? Because there is a section of the spinal cord, so there is no connection to the brain. So how do you feel phantom pain? And the guy below fell from a scaffolding about 10 feet or 20 feet high. He broke his C7, spinal cord section at C7, and he was paraplegic. He couldn't move anything. But then he said that his legs were way up. He felt his legs going up. His legs were not going up, but he felt his legs up. So that couldn't be explained by these theories. So then Melzack sat down and said, okay, we need to explain these things. And not only that, a lot of other pain entities, like fibromyalgia, guys, fibromyalgia. How do you explain fibromyalgia? So you got to explain fibromyalgia. And CRPS, complex regional pain syndrome, there are entities which cannot be explained by simple gate control theory. So you had to have a better theory to explain these phenomena. So phantom limbs and phantom body experiences in people with total spinal sections raise several questions about pathways in brain function, because the brain is completely disconnected from the cord, right? So these observations, and also most chronic pain syndromes like fibromyalgia, CRPS, do not have a discernible sensory cause or are characterized by intense pain that is disproportionate to input, reveal that the brain itself can generate every quality of experience, including pain, which is normally triggered by sensory input. So now we're talking about the brain itself being capable of generating all experiences rather than having a peripheral input or stimulation. That's when they came up with the neuromatrix theory. How many of you have seen the movie Matrix? Show of hands. They are based on this theory, neuromatrix theory. So the Canadian guys, two brothers, I think, did the movies, and based off the neuromatrix theory. And I know this very well because this was my dissertation for my fellowship. So I actually called Ronald Melzack to defend my thesis. I called him in Canada. He couldn't come, but he was happy that somebody was doing his theory. And so Melzack's analysis of the phantom limb phenomenon led to conclusions that point to a new conceptual model of the nervous system and led to the development of the neuromatrix theory. So what does Melzack say in this theory? That there is an anatomical substrate of the body self. It's a large, widespread network of neurons that consists of loops between the thalamus and the cortex and between the cortex and the limbic system. The entire network, whose spatial distribution and synaptic links are initially determined genetically, so you're born with some of these links, and later on they're sculpted by sensory inputs. That is labeled the neuromatrix. So now you can start making sense now, right? So you don't have to have sensory input. So you're born with certain genetic circuits in the brain, and then that can be modulated by sensory inputs. I'll give you a good example, guys. If you put your finger in the fire, right? You get burnt. But then again, that memory is seared into your brain. That memory is seared into your brain, and every time you see fire or you go near it, you can still re-experience the same pain that was there when you put your finger into the fire. So you're not putting there is no sensory input. You're not putting your finger into the fire there, but you can still feel the same sensation. Or for that matter, even smells, your childhood smells. You go somewhere, you get a smell, it reminds you of your childhood. There is no sensory input, but you can feel it. So that's what the neuromatrix theory is about. Simply stated, the neuromatrix theory gives us a model that involves two components: Pain is produced not by putative tissue damage and the peripheral nervous system that surrounds it, but rather by the central nervous system, the brain and the spinal cord. Various parts of the brain and spinal cord work in combination to produce the multiple aspects of the experience of pain. So we are moving away from the Cartesian principle of peripheral injury. So the neuromatrix theory guides us away from the Cartesian concept of pain as a sensation produced by injury. So we no longer have to have an injury to cause pain. Inflammation or other tissue lesions, and toward the concept of pain as a multi-dimensional experience produced by multiple influences ranging from the existing synaptic architecture, which is determined by genetic and sensory factors, to influences from within the body and other areas in the brain. So you need, everything you need is within you. So you can generate any kind of experience within you without any outside peripheral tissue damage. That's what the neuromatrix theory gets us. Having talked about, this is the last theory that now is holding good to explain pain. There is not another theory that has come after the neuromatrix theory. So coming to pain management today, what is pain management today? It started as an offshoot of anesthesiology, but it has evolved to be a distinct subspecialty over the past 30 years. Several fellowships and training programs in pain management throughout the United States, and now they're also coming up in India. I trained in one of the fellowships in the United States with Dr. Prithviraj and Dr. Rax, and there are a lot of fellowships like that in the US, and now we have fellowships coming up in India. In fact, as recently as last week, the Indian Association for Pain Management has started a one-year fellowship in pain management. So that is last week. We are talking about last week. With rapid advances in medical technology and imaging techniques, interventional pain management has taken center stage in recent times. So a lot of interventions are being done. That's why interventional pain management is in the center today. So what is pain management? It's a multidisciplinary field which involves several modalities of treatment. They include pharmacological therapies, interventional techniques, psychological therapies, physical therapy and rehabilitation protocols, complementary and alternative modalities like what? Like acupuncture, chiropractic, yoga, meditation, hypnosis, relaxation, tai chi, music therapy, aromatherapy, magnet therapy, etc. and etc. This reminds me of my professor Buchalingam. You guys remember Buchalingam? Yeah. So he used to tell us, he was a very profound philosophical guy, and he used to say, you know, patients go to, you know, homeopathy, allopathy, naturopathy, this pati and that pati, and if nothing works, they go to Tirupati. So even Tirupati works. So something like that: acupuncture, chiropractic, yoga, meditation, hypnosis, and. But anyway, coming to pain syndromes, as a pain management physician, what do we see? What do we see every day? One, low back pain. That's 70% of my practice, guys. 70% of our pain management practice is low back pain. And then headaches. Of course, we see headaches, cervicalgia, which is nothing but neck pain. Cancer pain is a big part of pain management. The superintendent was stressing, and the other guy was stressing about cancer pain, right? So, and arthritis, fibromyalgia is a big part of my practice. Vascular pain, acute pain. I don't do much acute pain, but there's a lot of acute pain as well. Abdominal pain, chronic abdominal pain, pelvic pain, neuropathic pain, phantom pain. Centralized pain, where the process is in the brain. Let's say a good example is somebody who's had a stroke and is paralyzed on the right side. They can't move, they can't feel anything, but they have a burning pain in the right half of the body. Again, we come back to the phantom sensation. So they have pain. So that's centralized pain. Failed back and neck surgery syndrome, that is big, huge. Where I practice, people have had 5, 6, 7 back surgeries, and so on and so forth. So it's very big. I know it's not as big in India, but it's getting there. Complex regional pain syndrome, CRPS 1 and 2, is very big as well. It's a very important part of pain management. So these are all the kinds of pain that we can see, that you can see as pain management physicians when you get to practice. So what is interventional pain management? It is a part of the comprehensive multidisciplinary pain management continuum. It involves the use of minimally invasive techniques and procedures to address the complex entity of pain. Remember one thing, guys, interventional pain management is just not sticking needles into people. That's not what it is about. It is a part of a continuum of treatment. So what do we do in interventional pain? There are several techniques we use. somatic nerve and plexus blocks in catheters. What is a somatic nerve block? Can anyone tell me what an example of a somatic nerve block, guys? Yes? You guys asleep? What's a somatic block, guys? Come on, you are postgraduates in anesthesia. You got to. What is it? I'm not going to go forward without you guys telling me. Come on. Is saphenous nerve a somatic nerve? Yeah? The brachial plexus is a somatic plexus. So any somatic nerve, a suprascapular nerve, is it a somatic nerve? So all these are somatic nerve and plexus blocks, right? Come on, guys, you need to be better at this than this. I don't like pimping people. I hated it when in the medical school also, but I think neuraxial blocks in catheters, a good example is epidural catheters, right? Epidural block, which is what you're going to learn, and putting catheters in there, spinal catheters and epidural catheters. Sympathetic blocks, lumbar sympathetic blocks, stellate ganglion blocks, these are sympathetic blocks. Disc-related procedures, you stick a needle into the disc. Why do you do that? You can do it for diagnostic purposes, for discography, or you can do percutaneous disc decompressions, right? You can stick a needle and decompress the disc. Vertebroplasty and kyphoplasty, you stick a needle into the vertebral body to put cement in there, right? If you have a fracture, you can put cement in there and use a balloon to inflate the compression. Neurologic techniques, cryoneurolysis, you freeze nerves, that's called cryoneurolysis. You heat nerves, it's called radiofrequency, right? And you pulse them, it's called pulse radiofrequency. Neuromodulation, you modulate the input into the brain and spinal cord. How do you do that? Spinal cord stimulation. You put a lead into the epidural space and stimulate the dorsal columns, you have spinal cord stimulation. Peripheral nerve stimulation, you stick a lead on a peripheral nerve and stimulate it. Intrathecal delivery of pharmacological agents using intrathecal drug delivery systems, that is morphine pumps. You put a pump inside the catheter inside the intrathecal space, and there is a pump that delivers morphine, dilaudid, other opioids or local anesthetics into the spine. What is the kind of equipment that we use? That is the single biggest piece of equipment that we use, that is a fluoroscope or a C-arm. We do most of our procedures under C-arm guidance, which is what you guys are going to learn tomorrow, right? That is the fluoroscopy. So, radiofrequency, simply put, you're heating nerves. That's all it is. Very, very simply put, you're heating nerves to kill them. That is radiofrequency. That is the equipment that you can see on the left. You're going to see all that. We are going to demonstrate all this for you. So this is just like a primer for you. Neuroaugmentation, spinal cord stimulation on the left. You see the leads that go into the epidural space. They are cylindrical leads and there are paddle leads. The paddle leads are surgically placed. The cylindrical leads are percutaneously placed, and those are the batteries that we use on the extreme left there. Well, I should say, right? The batteries that are used for spinal cord stimulation. This is for intrathecal implantation. You use pumps, and these are the two pumps. Cardman makes them, and Prometra makes them. Murli, are these both available in India? Cardman? Okay. Medtronic, I think, Medtronic is still there, yeah. So how's pain management doing in India these days? So it has developed into a specialty over the past 30 years and has made rapid advances in techniques and technology in the past 10 years. The advances in technology in pain management have been brought to India, and today India is on par with the rest of the world. I can tell you without any hesitation because really guys, really every technique and technology that I've mentioned is in India. So it's not the lack of technology. So everything is here. I personally have brought a couple of new technologies here like hydrocession and spinal cord stimulation. So I know for a fact that everything is available in India. The awareness about pain management is not up to par in general public as well as medical professionals. That's why we are doing this today, right? So the awareness, to create more awareness. Dr. Joshi has been doing this for the past 15 years. He's part of a traveling pain school. He's established fellowship. So please give him a hand. Yeah. On the spinal cord, it's between the peripheral nervous system and the central nervous system. So if you stimulate that, I'm not going to show all that, but look at the dorsal root ganglion there, And then if you look at the bottom picture, there are 3 stimulator leads going into the dorsal root ganglia there, right? 3 levels. You see the electrodes there? That's the 3 levels of dorsal root ganglion stimulation. Future for pain management in India, it will continue to grow. There is no question about it. As a specialty in India, we need to establish quality pain management centers throughout the country, which is what we are trying to do, which is what I'm trying to do, I've been trying to do, and which is what Dr. Joshi and other people have been trying to do. The stress on the word quality pain management centers is the stress there. So not any kind of pain management center, but quality pain management centers. Pain management education needs to improve with the establishment of fellowship programs in pain management in the premier institutes like All India Institute, PGI, JIPMER, and when they start fellowships, then everyone else will follow. I don't know, we have been talking to AIIMS how long, Murli? Like, okay. 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 So they tell me that there's a DNB program that's going to come up for pain management. So that's great. If it comes up, that's an awesome leap forward in pain management training. Awareness in the public and also among the medical community needs to increase significantly, a lot. And once again, the programs like this is why we do this. So overall, the future for pain management will be very bright if all of us work together. And that's it, guys. Thank you.